And we're live.
Hey, how about that? And good morning. Wow, it's really nice to see you. We good?
To Carolyn, yeah.
Oh, dear Dr. Rosensweet, good morning to you. And good morning to everybody coming up. My name is Carolyn, Dr. Rosensweet, and we're going to do our questions. And we are going to get started, hoping everyone is well. And again, a good morning. It's early, I must say. So, Dr. Rosensweet, question number one comes in, and we're going to be talking about the 24-hour urine testing here. Since the lab testing, as in 24-hour urine testing, shows what is happening during the 24-hour period tested, it would make sense. This woman is writing, at least to me, especially when the person is symptomatic or symptoms are worse during the month, to see where the imbalances are at that specific time. Do you agree with this, Dr. Rosensweet? Yes or no?
No, I don't.
Okay.
There's one really terrific and optimal time to test, and it's when a woman has gone through a discovery process of her optimal dosages. And to test her at any other time, I find not only not is unnecessary, but it costs her money. And
Yeah.
it's so elementary and relatively simple to start with a patient who's having symptoms of menopause: hot flashes, night sweats, can't sleep, mood changes, libido loss, muscle strength loss. And we know that each one of those symptoms relates primarily to a given ovarian hormone that's low. So we start replenishing the ovarian hormones, and we gradually increase them. And best case scenario, as the woman's being treated, her symptoms alleviate and she
Yeah.
feels better. And then there's a magic moment when she says, and it's usually somewhere between the third and the 6th month of doing a treatment process, that she goes, wow, I feel so much better. That's the appropriate time to do a hormone test on her, because even though a woman feels better, it doesn't mean that she's in the proper or optimal amounts to, for example, protect her bones. You need a certain amount of estrogen to protect your bones and to protect the health of your vagina. And even though women can feel better, 50% of the women, according to a study that we did, don't have quite enough to protect their bones and their vagina. And 25%, even though they feel good, they're on dosages that are a little too robust that could lead to breast glandular cell proliferation. So the final step there of testing is really a step to address fine tuning of a woman's program. Now, are there exceptions? Well, just in general, when a woman has had no periods for any length of time, what we know for certain about her ovarian hormones is they're super low. She can be having all kinds of symptoms, but we know that if we were to test her, her hormones would be super low. So we don't want to incur a unnecessary charge to the woman. She gets to pay $300 for the privilege of learning that her hormones are super low. So that's not a useful time to test at all. And then if a woman's in the perimenopause, that means she's having irregular periods and could be having a bunch of symptoms. There's such an irregularity to the ovarian output. The brain and the pituitary, so to speak, realize that the ovarian hormones are declining, so they can try and jumpstart the ovaries again by putting out a stimulating hormone to the ovary. And they do, and they get a burst of that stimulating hormone. And then you get a real high peak of an estrogen, for example. But the ovary can't keep it up. It's losing its oomph. And so you could test a woman who's having hot flashes, for example, and can't sleep at night, And yet, you see, if you test her on the wrong day, she's going to have a super high estrogen. And estrogen's the very thing she needs. So it's very deceptive. So it does not help to test hormone levels in a woman in the perimenopause or in menopause. In the beginning, we test 100% of the women, but we do so when they say, oh my God, I feel so much better. Now, there's a rare, and this is the one exception, there's a rare, unusual situation where we're having a real challenging time figuring out the optimal situation for the woman. And so rarely we'll do a test then to see is she absorbing the hormones? Is there some imbalance? And the only criteria we'll use is that she's religiously uh, taking the hormones at the proper time every day in the proper amount for a week. And then we'll test her and we'll get clues if it's related to
It could be a
hormones.
week,
We
really.
like it to be a week. We like a woman to be on steady dosages for a week. Could be less, could be 5 days, could be 4 days. But a week gives us a margin of safety there.
So when one is testing during the 24-hour urine, one is still taking her hormones, correct? As
Correct.
per
That's very
usual.
important. And occasionally that error is made for a reason I don't understand, but the instructions are pretty clear. Be sure and take all your hormones 7 days prior to collecting the urine, and like you're saying, Carolyn, while you're collecting the urine, be sure and take your hormones exactly like you always do. Then we get a real-time evaluation of what your hormone levels are while you're taking them. That's why we want to. That's what we really want to know.
Absolutely. Because I know that oftentimes women will say, well, my doctor didn't test me at the very, very beginning. There's a little confusion around that. And so
Yeah,
yeah,
it's very customary for anytime someone goes to a doctor's office to get some sort of testing done. And I have seen that it's hard to imagine why in the world wouldn't I get my hormone testing done? Because if you're in the perimenopause, you're going to get confusing results.
yeah,
And if you're in menopause, we don't want you to have to pay $300 for the privilege of seeing that your hormones are super
right,
low. That's
right,
why you're not menstruating. You need these
right.
hormones to menstruate.
I'm sorry for
Mm.
laughing, but I hadn't had my period for 17 years, and I hadn't made a hormone in probably that long, and they wanted to test me that day. I was like, no, I don't think so. I don't I
Mhm.
don't need to know what I know, you know,
Right.
for me. Anyway, well, thank you. Thank you for that answer. So if someone is highly symptomatic or symptoms are worse during that month, it's just you don't need to test like right that second.
Not at all. The symptoms point to low hormone levels, and we initiate therapy with lesser amounts than we would expect. They're going to be the final answer.
Yeah,
Gradually increase those hormone levels until a woman's symptoms disappear.
yes,
And if it happens to be that a woman goes too high, well, there's pretty distinct symptoms of taking too much hormone.
yes,
For example, estrogen stimulates breast glandular tissue. So if you have too much estrogen, you overstimulate breast glandular tissue and you get breast tenderness, breast fullness, breast enlargement, nipple tenderness, nipple pain. These hormones they're the most potent biochemicals in our body. So in excess of them, they speak very loudly. They cause enough trouble that it's pretty easy to recognize most of the time.
yes, yes.
Not
As you
always.
had
There's
said,
exceptions. There's exceptions. Some women, when their estrogens get super high, they get high, but super high estrogens are not a long-term strategy for anyone. So we're alert about this. Anyone who's trained in treating women knows about these little idiosyncrasies that can occur.
well, little idiosyncrasies are really big, beautiful things, actually, to learn about for sure. Thank you for that answer. I'm going to present a question. I apologize. I don't exactly know how to pronounce this word. this comes from a woman who writes in often. She's lovely. She is not in the USA. I do believe she's in the Netherlands. And she said, I'm wondering if taking, here's the word, Ututistan ultra.
Spell it for us.
I believe it's Utogestan.
Hmm.
Yeah, vaginally. Anyway, she's taking I apologize for not looking this up. I didn't. Judistan vaginally will change my estradiol levels, and not taking the oral kind, which she did. If I do take this estrogen vaginally, is this likely to cause estrogen dominance? I
Would
feel
you
there's
spell that for me?
estrogen dominance.
No, I'm
Oh,
sorry. The name of the
I believe it's Utogestan.
I'm looking it up.
Yeah, thank you. Could be Ultogestan. Oh, sorry. Urtogestan. Micronized progesterone.
Yeah, it's a progesterone, and that's what it is. It's a micronized progesterone. It's good stuff.
Oh.
It's bioidentical micronized progesterone,
Well,
and
so thank you. Oh, it's in Ireland, so I just got that all wrong, and
yeah,
I really apologize. I really apologize.
it's and progesterone is great for women. Women
Right, but if
getting a decline in progesterone early in their lives, often in the early 30s, mid 30s, significant decline, even though they're still ovulating, and you must ovulate to produce robust progesterone. And then at menopause, the progesterone tanks, and a woman's body is used to 100 times more progesterone than she is estrogen.
isn't that
Progesterone is
something?
a very, very important hormone. And my goodness, it plays into so many factors, including mood, sleep. Many women will have states of anxiety or even depression and feel so much off kilter that they're so much not themselves. And then you give them progesterone and bingo, they feel so much better. It's a big deal.
Yes,
These are very powerful hormones, these are very powerful biochemicals, and the absence of them very often causes severe symptoms. So, utrogestan, a micronized progesterone, is good stuff. Vagina is a
you
good way to take it. We use progesterone, micronized progesterone, in an organic oils formulation that we recommend that women apply to their skin. Some women do better on oral progesterone, micronized progesterone, in varying dosages. But yeah, progesterone, celebrate it. And we like to help a woman find her maximum dose of the progesterone. It can make so much beneficial difference, and especially just things that a woman doesn't feel necessarily, like bone. Progesterone is the only hormone that stimulates the osteoblasts that lay down new bone. So especially when we see osteopenia, osteoporosis, we're going to go aggressive on the progesterone. You can't go too aggressive on the progesterone because a woman won't like it, because it's so calming.
right.
If a woman takes it at bedtime, if she takes too much, she's going to wake up the next morning with a hangover, feeling like she had taken an overdose of a sleeping pill. So these hormones again speak loudly. It's for most of the time, not all the time, an overdose is going to be easily identified by lack of well-being, some kind of overdose symptom, and we describe those symptoms in detail, and they're in our book, Happy Healthy Hormones.
Which is downloadable, which many, many women know because I'm always putting it up on the group for sure. You can download it free, the PDF copy. It's really quite good. So she's asking, if she's taking this vaginally, is it going to change her estradiol levels? Um, is it likely, if she's taking it vaginally, that this is going to cause estrogen dominance? She goes on to say, I feel there's so much going on in my body and my brain, which of course we understand. But the estrogen dominance thing is really kind of her point.
No, it will not. Estrogen is an independent hormone. Progesterone is going to balance the stimulatory effects of estrogen. So it's going to counter any overstimulation by estrogen. If she's in menopause, her estrogen's super low. And if she's in perimenopause, the estrogen can be low and the progesterone can be lower. And so taking the micronized progesterone is going to help balance that. So it's going to do the opposite of support estrogen dominance. It's going to counter estrogen dominance in
Thank
the
you.
proper way. It's going to quiet down estrogen dominance. It's the big calmer. Estrogen's the stimulator, progesterone's the calmer. It's going to balance it. The only theoretically way that progesterone could increase the effect of estrogen is it is true that progesterone does facilitate the action of estrogen in estrogen receptor sites.
Ah,
But I have never clinically seen this be an obvious thing where you give progesterone and you activate the estrogen. Although, caveat, there are some women, if they're in the perimenopause and they're having hot flashes, it means they're low in estrogen. Some women will respond to progesterone alone. And we think theoretically the reason that it does that is it helps activate the estrogen receptor sites receptivity to estrogen itself. Estrogen functions better. But these are highly technical things. You
right.
take progesterone, you're going to balance estrogen dominance. It's going to be good for you all on its own. That's going to be the main thing about it. So every woman should be on all hormones, just like all men should be on the proper hormones. And progesterone is one of the key ones.
I want to interject my own question here really quickly, if I may, because you just made me think of it with the androgens and just anyway. Should men take the androgens?
Well, the androgens are testosterone and DHEA.
Correct.
All men get decline in testosterone and DHEA. If they want to feel like decent human beings, they ought to, especially if they want to function in many different ways, including sexually. Yeah, 100%.
Okay. Yeah.
Very rare for a man to have decent testosterone levels past the age of 50, 60. Same thing's happening. When we're young, we're producing a large amount of these biochemicals, and as we grow, when we're at the age of 20, we're producing the maximum amount, plus or minus a couple of years, and we're gradually declining in output, men and women.
Yes. Yes. Thank you for that. I apologize for the side note. It was just came up. Well, that's a good answer. Thank you very, very much for that. Yeah, she's having a tough time finding her balance there. Um,
There's some
my
interesting questions that have come up, and do you want to ask some of those?
Sure, absolutely. Well, there. Yeah, which one would you like? I mean, there are quite a few.
Well, I'll
Um,
start with them. Uh,
okay.
what's your thoughts on estrogen face cream? Can it increase levels? Women taught me this.
Hmm.
I was treating women in menopause with an estrogen biased, and we have it in organic oils. And women taught me, they said, what I do, I put most of it on my arms, but I save a little bit on my hands to rub onto my face and neck and back of hands every day
Yeah.
because it's so good for the skin. And so estrogen is really good for the skin, and you bet you it'll absorb. It's going to absorb. The skin has a nice blood flow, so it will absorb. But yeah, a little bit of estrogen. What we recommend is you're applying the majority of your daily bias to your forearms or the back of your shoulder, and other places are possible too. But save a little bit so that you finish off by rubbing the final amount of estrogen on your face and neck and back of hands. Compounding pharmacists all over the world, they almost every single one of them has their own special face cream for women. And what do they put in it? Estrogen is one of the major components because estrogen is so good for the skin. It really means the difference between, like, think of a 20-year-old woman's skin and an 80-year-old woman's skin. There's often a very big difference there, and the difference primarily is estrogen for a lot of technical reasons. So yes, and it will absorb.
But what
So
is this gonna make your 24-hour urine go off the charts? I mean,
no, it's always going to be dose dependent. How much are you applying? Like, for example, if you're applying 3 drops of bias when you're at sleep time, you're putting it on your forearms, you can rub your hand on your forearms to pick up some of the oils and then rub it on your face. You're still applying the same amount, and you're applying it to two good absorptive surfaces, the soft forearm and the face. And so it's not going to affect it in any significant way.
well, we have another question here too, that says, "I tried to increase my progesterone once and started bleeding."
Yeah,
Oh,
and you can. And I've never understood the mechanism for this, but there are some women, and it's usually in the perimenopause when you've got adequate or decent amount of estrogen, enough to bleed, and you add in the progesterone and you get the bleed. I don't understand the mechanism of that, but this does happen. Now, in the perimenopause, almost universally, bleeding is an erratic thing that's eventually going to go away because the uterus is healthy and it's just an erratic time. But if a woman's been in menopause for quite a while without a period and she gets a bleed, um, often if she's being treated with hormones, that is a hormonal balance issue. However, if she's been in menopause for a while, she hasn't had a period for a while, we want to check that bleed out. We want to do a transvaginal ultrasound to make sure that that bleeding is not coming from an abnormal something in the uterus, like a uterine cancer. They're rare, but it's extremely rewarding to pick up an endometrial cancer at an early stage. And endometrial cancers announce themselves by irregular bleeding. They're oddball bleeding. Woman's been in menopause 3 years and she gets a bleed. Where did that come from? So even some of those bleeds, there's nothing really adverse going on, but we like to check them out. So when a woman hasn't had a period for a long time and she gets a bleed, we want to send her to a gynecologist to get a transvaginal ultrasound. It's such an easy procedure, relatively speaking. I mean, who wants to even get in the car and drive to a doctor of any kind? So easy, yeah, easy for me to say. But
yeah.
as far as medical procedures go, this is very, very. I'd like to say non-invasive because it doesn't hurt the body. Let's put it that way. And it can pick up so easily something abnormal in there. So we like to see transvaginal ultrasound. I know I'm repeating myself, but if a woman has an unusual bleed, we want to check that out. We want a gynecologist to check that out. They've got the tools in their office. They know exactly, they have every tool they need to evaluate an abnormal bleed, including to reassure you that, hey, no, this is just nothing. It's related to the hormonal balance. They can make that conclusion too. And
Right.
then there's another thing here. Something. Does it matter if the progesterone is taken in a pill? Well, this is, even though this is progesterone has also been provided in a capsule or a pill, capsule usually, and it's been done so for 50 years.
Mm.
Compounding pharmacists have been putting micronized progesterone into capsules, and then even the pharmaceutical manufacturers Oops, I will cancel this. Sorry. Pharmaceutical manufacturers have been putting micronized progesterone in capsules, and it's a good way to take it. This is different than taking estrogen by mouth.
Right.
Best case, we don't want to prescribe estrogen by mouth. It does some funny things. Like when the birth control pill first came out, in fact, ever since it's been out, we know that a certain small number of women will get blood clots in their legs or even in their lungs from taking the oral birth control pill, and it's really the oral estrogen in the birth control pill that's causing this. And oral or estrogen, when you take it orally, it goes from your stomach to your small intestine, then via lymphatics directly to the liver. And so 80 to 90% of it gets processed in the liver prior to getting distributed to your whole body. That's different than applying it to your skin.
Maybe
When you
that would
apply,
be the same with a capsule, as
pardon?
opposed. That would be the same for a capsule that has more of a liquidy kind of thing in it.
Yeah, a capsule. When you swallow a capsule of micronized progesterone, whether it's in oil, the progesterone could be in oil in that capsule, or it could be in powder in that capsule. But when you swallow a hormone that's fat soluble, goes to your stomach, then your small intestine, and then is absorbed into the system that goes right to the liver. And because the liver gets to see it, 80 to 90% of it is processed by the liver.
Right.
Not a problem, but it does call for a couple things. First thing is you have to give quite a bit more orally because you're only going to get 10% making it through, 15%, 20% making it through. And it turns out in the case of estrogens, when that first pass through the liver, that's what it's called. First it goes through the liver, then it goes to the bloodstream. First pass through the liver, that produces inflammatory proteins and coagulation proteins, proteins that enhance blood coagulability. So a certain number of women, that enhanced coagulability leads to a clot. So I can't think of one reason in the world that anyone would want to take estrogen orally, even though probably by far, the vast amount of estrogen that is prescribed by mouth, but not by me, not by the physicians and nurse practitioners and pharmacists that we train. No way. And progesterone, however, does not have adverse effects when prescribed by mouth, so that's okay. Testosterone can injure the liver when prescribed by mouth.
Ah,
You can't even get it anymore, I don't believe. I mean, occasionally someone comes out with an oral testosterone.
I don't think I've ever heard of it.
Yeah,
Um,
it's because it's known to be damaging to the liver. So testosterone we want to give topically. We want to apply it to the skin or mucous membranes. But oral progesterone is fine. And some folks believe that first pass through the liver produces a metabolite that is beneficial for sleep. Well, we know it produces the metabolite that's beneficial for sleep. So some women who we're always going to try oral progesterone if a topical progesterone is not giving a woman enough progesterone to help her sleep. So yeah, oral progesterone, good stuff. And here's a woman who takes 50 milligrams of sublingual progesterone and makes me bloated. Not sure what to do. It is a challenge. Progesterone is the great relaxor. And in pregnancy, that relaxation is so deep that it relaxes the ligaments in the pelvis, ultimately for a baby to have an easier time passing through that pelvis. And it relaxes everything else too. It relaxes the lower esophageal sphincter so women can get heartburn. And it relaxes the intestinal tract so women can stuff can spend too much time in the intestinal tract and A woman can feel bloated because the intestinal movement called peristalsis isn't as vigorous. So you got to fiddle with progesterone there or fiddle with the intestinal tract
That's a great word, fiddle with. Yeah.
because midlife, a lot of us have issues in the intestinal tract that are not obvious. We don't have stomach aches, but we can have imbalances in the intestinal
Mhm.
tract from indiscretions in eating or traveling to funny places or the long-term taking of antibiotics. We can have a disturbance in the intestinal health. Excuse me, the healthy bacteria that belong in there, 3.5 pounds of them. And this is the subject that's becoming more and more popular. Whenever you hear the word probiotics, really what they're trying to address there is the imbalance that can take place in the bacterial, our friends and neighbors in our intestinal tract. And functional medicine providers have become very excellent at this. Those are the ones you want to go to. So, what am I saying here? Bloated could be as simple as the progesterone is relaxing that intestinal tract too much, or it could lead to other issues that the intestinal tract was on the verge of relaxing too much in general because it had imbalances in the bacterial population in there. And that's what's getting revealed here. Or it didn't have enough, you didn't have enough magnesium, for example. And so the intestine wasn't operating correctly. So that bloated shouldn't be just a matter of just, well, I'll forget about it and I won't take this progesterone. It would, best case scenario, it leads to an investigation of that intestinal tract that someone who's got a functional medicine background is really well trained to do. And there's another one. You can have an intestinal tract that's really just living on the edge of not doing well.
Yeah.
And one of the main reasons it's living on the edge is there's not enough thyroid hormone. People who get functionally low in thyroid, they can really easily get constipated. So I'm giving you examples
No, but I mean, who would
of,
have thought? If you don't know, you don't know what you don't
yeah.
know,
So you
right?
just don't want to say, well, the bloating is all about the progesterone. I just won't take progesterone. Well, we would never stop there. We'd want to go, hey, why did you get bloated so easily on progesterone? You weren't taking this knockout dose of it.
Yeah,
50
right.
milligrams is not a knock you out dose. It's a low dose.
Yeah,
So
and you're
why
pretty
are you getting
generous.
now? Having said all that, there are women who've got a special sensitivity to progesterone, and we have to be very careful with them. What the typical issue is that they haven't their body hasn't seen progesterone for many years, like
Yes.
hysterectomies when the ovaries are removed, no hormones for many years. Progesterone receptor sites go to sleep, go dormant, and if you flood them too much, you only get symptoms. So 50 milligrams could be too much right out of the gate. Maybe you need 5 milligrams, then 10 milligrams, then 15, then 20, then work your way up over the course of a year or two.
Yeah.
So you gradually awaken those receptor sites. So if all this sounds like there's a lot of moving parts, well, best case scenario, there is.
That's right.
People who are trained in this, they can follow the bouncing ball and try and solve these issues. Rarely we have challenges solving the progesterone sensitivity, but so we ought to be able to do it sooner with most cases.
And it's very interesting you bring up the thyroid there. I mean, because many of us just don't know that, or
Yeah,
would have ever thought.
yes, and there's a lot of stuff like that. We don't know what we don't know,
Right.
and then lo and behold, there's someone out there who does know it because they've devoted their career to it. 10, 20, 30, 40 years. You do know it. There's
Yes.
some interesting questions here.
Very much so. I'm putting that in your hands.
Okay, progesterone capsule taken rectally? Yeah, it works really well. However, why would you do that? when it works so well on the skin or taken orally. So I just not exactly certain if why someone would want to take something rectally. I've taken things rectally. Can't say it's the most fun thing I've ever done in my life, so rather put it on my skin. Um,
Can't imagine.
Progesterone creams, it always makes me depressed and my face breaks out. Yeah, it's a funny thing about human beings. There's all kinds of variables that happen. Even though something might be known to have certain effects, when you look up in technical journals or technical textbooks, all the variable effects, there's going to be some women that it's going to make a little, they have a sensitivity to progesterone, and progesterone is the great calmer. Well, if you get too much progesterone, you get too calm. Otherwise, you can get depressed from it. It's not common, but it does happen. And even progesterone, there's a biochemical pathway where progesterone can become testosterone. It's a pretty rare pathway, but yeah, sometimes this happens. And you know what this points to? The most important thing I always believe I say on this podcast or this Facebook Live is a woman has a job. So do men. I mean, this is not different for men.
No.
Midlife, we can get so much advantage and so much benefit by getting our hormones replenished properly. But we want to go to someone who really has taken this on as a major interest because we're not taught this in medical school or internships or even residencies. Hormones have not yet emerged as a specialty. They need to. There's reasons why they haven't emerged as a specialty. However, there are thousands of physicians, nurse practitioners, PAs, and advising compounding pharmacists who have taken this subject on. They're fascinated by it. They love the results they get. And they've gone on and take special learning courses. They've got, I mean, for example, we have what I do 80% of the time is involved with training physicians and nurse practitioners and others how to treat women in menopause. So there's a body of knowledge. But the woman's job is not to get that body of knowledge, it's to go shopping and find someone that does have that special training, that does have that, and interview them or interview their office manager. Because not only do you want to find someone with the excellence, you want to find someone you like, that you can trust and communicate with and work with, because it's a process. So that's your main job, is go shopping for that person. And here's how to go shopping for that person. You can go to your local compounding pharmacist. There's about 8,500 of them in the United States. They're the ones who are filling prescriptions of compounded bioidentical hormones for the physicians and nurse practitioners and PAs in their community. And I say go into the pharmacy and talk to the compounding pharmacist. Don't try and do it by phone call. It's a very personal communication they're going to make. And what you want to ask them is, gee, if your wife or you wanted to get treated in menopause, which of the many doctors and nurse practitioners that are writing these prescriptions would you recommend here in Pachuch, USA? Who would you recommend going to? And you're liable to get, see, they know who the smartest ones are. They know who the ones who are doing the best work are, because they're filling the prescriptions, so they get to see. So that's one resource that's great. Another resource that's great is to contact our group. And we have trained physicians in nurse practitioners and PAs all over the United States. And there's states that we haven't trained people in, but in a lot of states we have. So you can contact us. And here's the best resource of all. If you're midlife, start talking to your fellow women, because invariably some of them are in menopause, and invariably they know someone. and can refer you to their favorite person. They know, oh yeah, I had to search around to find this particular nurse practitioner, but boy, she's great. She's a great person, and she really knows how to do it. So your friends in your network, that's how you find. That's your main job. I do not recommend the testosterone troche
I was just going to ask that question. Yes.
because when you put something under your tongue, the general theory is it would all absorb through the right under the tongue through the oral mucosa. And indeed, some of it does absorb through the oral mucosa. But anyone who's ever put a troche in there knows that it takes a while for them to dissolve, and you wind up swallowing part of it, which I don't really favor at all because you don't know what percentage. So how are you going to get your daily dose optimal and steady? And swallowing testosterone is not a healthy thing. There's some people it's going to injure their liver. So I'm not a fan of troches testosterone at all.
Got it.
But I don't want to interrupt the flow of the many questions that were sent into you. So why don't we return to those, Carolyn?
We've done a great job with this. Thank you so much, Dr.
Mm.
Rosensweet, for acknowledging the questions that have come up. My third question comes in. I'm a breast cancer survivor, 25 years now. I was cured. It was stage 1. I do test via blood, and I'm wondering what advantages would I get from using a Dr. Rosensweet's method for one, but especially the 24-hour urine testing. Which metabolites are tested, and why do I even need to know them? Why do they matter if they're just what my body eliminates anyway? Thank you. This is from a very bright woman who's an NP. She's great. Um,
Well, here's the main thing. I'm assuming this woman has not been treated with hormones. Is that correct?
no,
She is being treated?
yeah. Well, she's Perry, so it's kind of back and forth. I mean, and a lot of
Well,
it's
no. She had breast cancer.
25 years ago, and she was cured. She's testing via blood for her hormones, and she's wondering what the advantages would be if she were to use your method, meaning, the oils topically.
Yeah. What I what's not said in that question about whether or not she's being treated currently with hormones. And I want to address the elephant in the room just in case she's not being treated for 25 years with hormones.
Okay, yeah, I don't believe that's so, but uh,
And the we've all, the world took a horrible blow by some misinformation that emerged through a false reporting of a medical study in 2002
yeah,
stated that there was increased risk for breast cancer in women who took something called Prempro. But it was not statistically significant in that study. But it got blasted out in the news, and people didn't read the study. And it scared women and healthcare providers all over the planet to ever treat women with hormones. And what they missed was that the women on Premarin and horse urine-derived estrogen alone had less risk for breast cancer, and women on Prempro had a statistically insignificant. What that means in medicine is don't draw any conclusions. You don't have any answers there. But it was reported out as if there was an increased risk. That's false. That study never said there was an increased risk. It said it was a statistically insignificant for Prempro. But, it was mishandled and exploded out all over the world. And the 18 million American women, the 40% of all American women in menopause that were being treated with Premarin and Prempro, that dropped to the very low millions
yes.
with devastating consequences to those women because
Many
everyone got,
years ago, and it's still.
And it's still going on. I mean, a study in 2017 showed that there was a return to usage, but it was only up around 6 million at that time. So the fear persists, and the fear is universal. And this is a woman who had breast cancer, but here's the actual science. And I've stated this many times, that we're all at risk for thousands of diagnoses, and some of them are not good. And we're all at risk for hundreds of cancers. And as a male, I'm at especially increased relative risk for prostate cancer, and there are reasons for that. And women have an increased relative risk for breast cancer. There are reasons for that. But here's the science. Women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who go untreated. And here's some further science. Women who have had breast cancer and have had that breast cancer properly treated have an increased relative risk for getting a recurrence than a woman who's never had cancer has of getting it. However, their risk of recurrence is less if they're treated with hormones.
That's
So
the
this is the
biggest.
science.
Yep.
And I summarize this in chapter 3 of the book that you can download from Carolyn's Facebook page. And I also give you reference to the Bible on this, which is a book called Estrogen Matters. It's by an oncologist who specialized in breast cancer. And so what this woman did not include was whether she was taking hormones or not for 25 years. And just in case she wasn't, I wanted to catch her up with the science, and she could really be caught up with the science if she reads Estrogen Matters. Now, let's go to the part of the question. Testing. There's no value in testing your hormone levels. If you're 25 years out of breast cancer surgery, you're probably in the perimenopause or deep into menopause. So you haven't had a period, or you're having all kinds of symptoms, and your estrogen levels, your progesterone levels, your testosterone levels are super low. So there's no need to test you. In fact, it's a waste of money to test your hormone levels. We test other things, but we don't test your hormone levels prior to treating you. And then if you're one of 75% of women who have symptoms of low hormones, in the process of treating you, those symptoms are going to go away. And when you say, oh my goodness, I feel myself again, the symptoms have gone away, we do want to test you. And gold standard to me is the 24-hour urine hormone test. And nothing compares to it. I only want to give you my best shot. The only thing I'm satisfied with women is the 24-hour urine hormone test. Although in New York State, you can't even do that. So you use blood tests as best you can. The questioner asked about metabolites. What does they show? And are metabolites related to the cause of cancer? Well, there's controversy about this. Some people say that how the estrogen is processed in the liver, in the processing, the biochemical processing, produces chemicals that are called metabolites because the process is called metabolizing. And there's 3 to 6 of these metabolites, depending on how you like to look at it. And some people say that means there's even studies. I use this hesitatingly because I don't see that they're fabulous studies. But when you stack up the studies, those who say that the metabolites are problematic and those who say they're not, it's hard to conclude what the truth is. Are the estrogen metabolites and how these things are processed related to the development of cancer, yes or no? Well, there's evidence for both sides. That's confusing. And here's why I think it's confusing. Health is our genetic propensity
Yes.
to be healthy. And if we but health also requires careful attention to what we eat, what we breathe, what we drink, the exercise we do or don't do, the toxins we're exposed to or not, and the elephant in the room being how functionally we respond to the stresses of life. Do we get way bent out of shape and trigger the whole biological cascade of fight or flight, which is a rough thing? It works great to run from the saber-toothed tiger, but it wreaks havoc with our hormones and our immune system, among other things.
Oh, yeah.
Suppresses the immune system.
Yes.
So the causes of illness and cancer, they're related to thousands and thousands of not good events. The time we decided to go to the fast food restaurant rather than cook at home. Oh, it was so convenient. Yet, there's some problems with eating fast food, restaurant food. Or the times we got stressed and we just got way bent out of shape and we dug ourselves in deeper by poor communication skills and we worried about this and worried about that. So I like to think of it in terms of, let's say we had a video of someone's life. And I'm going to wrap this in 1 minute because I have a hard stop. And a videographer filmed someone from moment of conception 24/7 to this very day. And then they had a magic editing button in which they edited out all the good stuff, all the love, all the fun, all the good healthy meals you ate, all the good air that you breathed, etc. What would be left behind would be thousands of events of not breathing enough, getting exposed to toxins, having a dysfunctional response to stress, which threw our immune system off. Thousands of these events. These are the causes of illness. So when you go to look at something like metabolites and you have trouble drawing a conclusion, you should, because they're not the cause.
Ah.
And you got to get at the cause. When I see abnormal metabolites, one of the first things I want to start thinking about is the liver. How's the liver doing? Because it's doing the processing. And if the liver is not doing its best job, is it under the influence of an intestinal tract that's not doing well? So does this sound complex? Yeah, it is complex. We're complex. But the urinary metabolites are not my 100% attention there. I want to know the big stuff, like how high are the hormone levels? Are they too high? Are they too low? How about the estrogens, the androgens? That means testosterone and DHEA and their metabolites, the corticosteroids. And, oh my God, Carolyn, it's time to say until next time.
It's time to say until next time. That's brilliant. Well, it's really good to see you, Dr. Rosensweet. I will start off with my last question in 2 weeks from now. We thank you for your kind time. Definitely. Thank you, everybody, for being here. Have a great couple of weeks. You know where to reach me. And blessings to everybody. We're going to see you
Thank you,
later.
Carolyn.
Thank you, David.
See you later.
Bye.